Hello, and welcome to the Congressional Hispanic Caucus Institute's 2022 Graduate Fellowship Program Capitol Hill Briefing Series. I'm Marco Davis, President and CEO of CHCI. This series is the culmination of CHCI's premier 9-month graduate fellowship program, which offers exceptional emerging Hispanic leaders unparalleled hands-on experience in public policy. This unique fellowship program seeks to enhance participants' leadership abilities, strengthen their professional skills, and increase the presence of Latinos in public policy areas, most notably in the areas of health, technology, housing, energy, social equity, child welfare, and education. CHCI is thrilled to be able to offer our graduate fellows the opportunity to share their perspectives on policy issues that they're passionate about and convene leaders in this work for an informative conversation. Now, we'd like to thank our Graduate Fellowship Program sponsors for supporting the program, including Facebook, the PepsiCo Foundation, America's Health Insurance Plans, BBVA, Casey Family Programs, the Walton Family Foundation, the American Petroleum Institute, DaVita, Wells Fargo, and CVS Health. You can keep today's conversation going by using the hashtag CHCI Fellows on social media. And please visit chci.org to learn more about our Graduate Fellowship Program, as well as our other leadership programs and special events. And we encourage you to reach out to our fellows via LinkedIn to find out more about their policy work and help them connect with job opportunities for when the program concludes in May. Now let's get to the briefing. Enjoy the discussion.
Hello, my name is Caroline Gonzalez-Scott, Vice President of Programs at CHCI. Join me in welcoming Congressman Paul Tonko, representing New York's 20th Congressional District.
I'm Representative Paul Tonko, and I represent New York's 20th Congressional District, as well as serve on the House Energy and Commerce Committee. I want to extend a warm welcome to all of you attending today's Capitol Hill Policy Briefing session. Over the last few decades, incarcerated individuals have faced serious struggles with their mental health. Approximately 10 to 25% of U.S. incarcerated individuals suffers from serious mental illnesses. And throughout the COVID-19 pandemic, fears of infection, increased restriction of movement and activities, and interrupted mental health services have profoundly impacted the mental health of incarcerated individuals, often for the worse. Importantly, Congress has a long history of taking action on mental health. Last year, the House passed 9 bills shepherded through the House Energy and Commerce Committee that would support mental health training, expand services availability, and address inequities. The House passed Build Back Better Act also included provisions to allow Medicaid to pay for healthcare services for incarcerated individuals during their last 30 days of incarceration, as well as funding for states to expand in-reach and other care coordination services post-release. These are critical steps in the right direction, but our work simply is not done. We must continue to discuss and explore new ways of addressing the mental health needs of incarcerated individuals. For this reason, I'm excited to introduce Tania Calle, who will be moderating today's panel titled Mass Injustice, the Mental Health Crisis Within the U.S. Criminal Justice System. Tania is the Congressional Hispanic Caucus Institute-DaVita Health Graduate Fellow, working within the Health Subcommittee of the House Energy and Commerce Committee. She holds an MPhil in Public Health and has conducted extensive research at the intersection of public health and policy. Moreover, as a first-generation American who has borne witness to the harm caused by unjust and inaccessible healthcare systems and policies to Latino and immigrant communities, she is a fierce advocate for health justice for all. Throughout her time on the subcommittee, she has worked on a range of issues related to mental health and substance use. We are very grateful for her time spent with us. Please join me in welcoming Tania Calle. as she will greet us with a great message, I'm certain. And I look forward to a thoughtful dialogue with these esteemed panelists. Thank you.
Thank you, Representative Tonko. I appreciate the kind introduction and commend you for all the work you do to advance health equity and justice through your service on the House Energy and Commerce Committee. Again, my name is Tania Calle. I use she, her pronouns, and I'm the 2022 CHCI-DaVita Health Graduate Fellow. It is my honor to welcome all of you to the Congressional Hispanic Caucus Institute policy briefing series entitled Mass Injustice, the Mental Health Crisis in the U.S. Criminal Justice System. I'm excited to moderate today's discussion alongside a distinguished guest panel on correctional mental health care. Since the 1990s, prominent public health and medical professionals have raised concern about the overrepresentation of individuals living with mental illness in prisons and the lack of quality mental health care in these settings. At the time, this was largely a consequence of the closure of many mental health facilities in the 1960s and the increased criminalization of mental illness and substance use during the war on drugs. Although several decades have passed, conditions have not greatly improved. Currently, there are 2 million people incarcerated in the US, and according to a recent study conducted by the Bureau of Justice, approximately 40.5% of incarcerated individuals had a self-reported history of a mental health problem, and 13.4% of incarcerated individuals reported symptoms of serious psychological distress. These rates are 2 to 3 times higher than the prevalence observed in the general population. And within the incarcerated population, women, biracial, multiracial, white, and Native American individuals report the highest prevalence of mental illness. Black and Latina individuals report relatively lower levels. However, new evidence suggests that these trends may be due to biased mental health screening tools that reproduce racial disparities rather than true differences in mental health status. Additionally, incarcerated individuals have limited access to treatment. Only 63% of state and 58% of federal incarcerated individuals report receiving treatment since admission. Black and Latina individuals have been found to have the lowest access to treatment. And perhaps most devastating, individuals experiencing mental illness are not surviving in prisons and jails. In the largest U.S. prison system, the Texas Department of Criminal Justice, incarcerated individuals with a diagnosis of mental illness made up slightly more than half of those who die by suicide. Further, incarcerated individuals with major depressive disorder, bipolar disorder, and schizophrenia were 5.1, 4.6, and 7.3 times more likely to die by suicide than incarcerated individuals without these conditions. These trends are evidence of a mental health crisis within the U.S. criminal justice system. And importantly, this crisis is not contained within the walls of a prison. When we apply a lifespan lens, individuals living with mental illness face a higher risk for lethal harm by authorities at the point of arrest and have higher rates of recidivism following release. Given that one of the aims of incarceration is to support rehabilitation and social reintegration, it is clear that we are failing. Time for action is long overdue, and while the path forward is not clear, I am grateful to the members of our panel who have fought tirelessly at the intersection of criminal and health justice to advocate for system-affected communities and their right to quality mental health care. Please join me in giving a warm welcome to our esteemed panelists. I would first like to introduce Shannon Scully, the Senior Manager of Criminal Justice Policy at the National Alliance on Mental Illness. Shannon provides strategic guidance on NAMI's criminal justice, diversion, and crisis response policy, as well as works closely with federal agencies and Congress. Thank you so much for being with us today, Shannon.
Thank you so much, Tania. And I want to thank the Congressional Hispanic Caucus Institute for convening this incredibly important conversation today. NAMI is the nation's largest grassroots mental health organization representing individuals with mental health conditions and their family members. Our alliance is made up of 48 state organizations and over 600 affiliate organizations located in communities across the country. In our work, we provide education and advocacy and are united by a shared hope of new innovative treatments, improved healthcare coverage, and support through recovery. As I start a lot of these conversations, I like to bring up a couple of main points to really as a foundation for the discussion. As you listen to this discussion, keep in mind that criminal justice reform and mental health reform go hand in hand. We cannot hope to address the overrepresentation of people with mental health conditions and substance use disorders in our jails and prisons until we begin to address the lack of access to affordable, culturally competent care, as well as early identification and intervention. We have to right-size the historic underfunding of our mental health system and continued misunderstanding and stigma that surrounds mental health conditions. Until we do this, our communities are going to continue to rely on the criminal justice system to address the adverse effects of barriers to mental health care. I also want to raise the point, because this often comes up in this discussion and rarely gets a very deep, kind of addressing. But our dependence on the criminal justice system to address mental illness is really rooted in an unfounded belief that people with mental health conditions are dangerous. Mental illness alone is not an indicator for violence. And in fact, people with mental health conditions are more likely to be victims of a crime than they are to ever perpetrate a crime. So there are a very small number of cases in which violence becomes a factor, and that is sometimes people's reality and experience. But that's a small number, and those cases should not be the driver for policy and the formation of our response to mental illness. So I'm going to leave you with that, and I'm going to turn it back over to you, Tania. So thank you again so much for your leadership in including NAMI in this discussion.
Thank you, Shannon, and welcome to our panel. I would now like to introduce Maggie Luna, a current Hogg Foundation for Mental Health Peer Policy Fellow at the Texas Center for Justice and Equity. Her work involves conducting research, coordinating activities, and advocating for the reduction of the prison population and policy transformation in the Texas criminal justice system. Thank you for joining today's panel, Maggie.
Hi, thank you so much, Tania, for holding this. This is so important to me. I am the Hogg Foundation Policy Fellow with Texas Center for Justice and Equity. At Texas Center for Justice and Equity, we advocate at the state level here in Texas to end mass incarceration and shift funding towards the community and supporting the community to reduce racial inequities in the criminal justice system. Also, this is extremely important to me on a personal level because I am directly impacted. I'm formerly incarcerated, and I also have lived experience with the mental health system within the criminal justice system. And today I run the statewide leadership council, which is through the Texas Center for Justice and Equity. And we are formerly incarcerated system impacted people committed to ending incarceration in the state. Our current criminal legal system is rooted in slavery and racism. And those consigned to Texas cages have been disproportionately and intentionally African American. Our system has devastated countries, countless Texans, communities, and denied members of those communities a viable path to sustainable, dignified life while intentionally excluding them from transformative processes. So we claim our right to inclusion and teach other people who are directly impacted to advocate at the state and local levels to make meaningful change for the people who are still suffering within the system. Thank you for having me.
It's wonderful to have you, Maggie. Next, I would like to welcome Dr. Karen Eichenberg, a full-time faculty member at the Grand Canyon University School of Social Work. Her research focuses on violence and abuse, and she has extensive experience providing services inside one of Georgia's medium security prisons for men. It is incredible to have you with us today, Dr. Eichenberg.
Thanks so much, Tania. Thank you for having me, and thank you to CHCI for hosting this for us. This is a topic very near and dear to my heart. Again, I am Dr. Karen Eichenberg. I'm a licensed social worker in the state of Georgia, and I hold a PhD in social work. My academic focus and practice was focused on trauma, family violence, and the intergenerational transmission of violence. Currently, I do work at Grand Canyon University. I'm a teacher for social work. I was invited today to be on this panel because of my work inside of one of the two men's mental health state prisons in Georgia. There are only two that focus on incarcerated men in the state. I spent most of my time there as a level 4 mental health counselor. I also ran and created programs that focus on trauma and rehabilitation for some of the general population men that were there. However, it took me less than 2 weeks of working in a state prison to realize how broken, corrupt, and abusive the prison system is in Georgia. After that experience of about 2 weeks, my calling quickly became correction reform. And my focus, while it is still on intergenerational transmission of violence, it now includes therapeutic rehabilitation in the carceral system, mental health and addiction services, and smart decarceration. Today, our focus is on mental health in the carceral system. And as I wanted to ask, as people listen today, I want everyone to remind them that these justice-involved individuals are mothers and fathers, husbands and wives, and sons and daughters. Being justice-involved does not mean you lose the right to be treated like a human. It means that you are dependent on the system to provide you with the care and that you need and deserve. 93% of people who are incarcerated return home. This issue impacts everyone that you know. In state prisons, approximately 25% of men and 70% of women who enter the system come in with a diagnosed mental illness, as you mentioned, Tania. These statistics for incarcerated youth are even more concerning. Between 71% and 85% met diagnostic criteria for at least one mental illness, and more than a third were diagnosed with co-occurring mental health and substance use disorder issues. While prisons and jails have the ability to treat our loved ones, their services fall grossly short of anything therapeutic or protective. In the free world, we all know how difficult it is to get proper mental health care treatment. Now imagine for a minute what it's like when you're locked in a system that views you as a monster. This system that glorifies staff brutality and turns a blind eye to the unspeakable horrors and abuses our loved ones witness and suffer. This system needs support from all of us in order to rehabilitate our loved ones and bring them home to us less and not more broken than they went in. Thank you for spending your Friday afternoon with us as we discuss the mental health care needs of the justice-involved individuals.
Thank you for joining Dr. Eichenberg and your incredible insights. I would now like to introduce Kate Ashia, the President and CEO of the National Incarceration Association. Driven by her personal mass incarceration journey as a parent, Kate leads fights for families who have lost or are at risk of losing their loved ones to mass incarceration and addiction. It is great to have you join us today, Kate.
It's really good to be here, Tania. Thank you so much to CHCI again for this extremely important conversation. Yeah, my name is Kate Ashia. I'm the President and CEO of the National Incarceration Association. We're a nonprofit that was formed, like Tania said, as a direct result of my personal journey with my son, Daniel. Daniel was sent to prison in October of 2012. The day he was convicted of armed robbery, he had used heroin and was whisked off to our local jail to await his transfer to Georgia State Prison on a 15-year mandatory minimum sentence for armed robbery. Daniel had no weapon, stole nothing, and hit nobody. The journey began that very moment of the conviction. The second the gavel went down, my family was put in prison along with my son. His journey was our journey, a journey that I had absolutely no ability to navigate. I could not figure out the simplest ways to help my own child. My child, who now is suicidal, who is begging for help. He would call me night after night, "Mommy, you got to get me out of here." It was so traumatic for me and my family. And I think this is why the NIA was formed. I know it was, because people just don't understand the massive impact that incarceration has on the family. So everything we do through the National Incarceration Association is through the lens and perspective of the families. We have a mission to help families navigate the journey of incarceration with positive outcomes and to push innovations throughout justice systems to correct, rehabilitate, cure, and restore for greater public safety for all. Our vision is that the justice and corrections system of the United States becomes a system of dignity, safety, and progressive personal improvement for all involved. And when we say all involved, we mean all involved. We're not just talking about the people that live in our prisons, and men and women that are suffering, like Karen said, these terrible abuses regarding their mental illness or substance use disorders, but also our officers and the staff that work in these dilapidated buildings. They are also ignored the plight of and the plight that they face. They're thrust into a very violent environment, working in long hours and underpaid in rural communities. We ignore our correctional officers just like we ignore those men and women that live in our prisons, and just like we ignore the families. And personally, my stance is that it's time for us to stop this. We've got to quit locking up sick people. It's healthcare, not handcuffs. Thank you, Tania.
Thank you for joining, Kate, and for sharing so much of your story. I will now introduce our final panelist, Tracy Gardner, the Senior Vice President of Policy Advocacy at the Legal Action Center. In this role, Tracy oversees both the New York and federal policy advocacy work related to substance use, harm reduction, and criminal legal system reform. It is wonderful to have you with us today, Tracy.
Thank you, Tanya. I'm very delighted to be here. As I said, this is a wonderful opportunity to work with, I hope, the future policymakers and congressmen and women who will change the landscape in which we're working. Again, Legal Action Center is a law and policy advocacy organization. And since the 70s, we have fought against discrimination against people with substance use disorder, people involved in the criminal legal system, and then HIV as it emerged, impacting this population. You know, the panelists before said just about everything that I would say, including the fact that we are still dealing with the impact of the war on drugs, the criminalization of communities of color, the deinstitutionalization, and then subsequent lack of investment in community supports for mental health, and that convergence came together to bring us to where we are. And so we are in a transformative time, but if we repeat the mistakes of the past, we will get what we've always gotten. I've been doing this work for more than 30 years, and my focus has always been on communities of color, particularly women and children and families. And we keep having an emergency response that doesn't heal and doesn't restore to the health emergencies in our communities all over this country. We have criminalized people with health issues of their mind. And I got to see how deeply entrenched that was during a short stint working in the New York State office of the governor, while I oversaw the mental health, addiction, and developmental disability programs. So I'm eager for the discussion today and to talk about how we can really take advantage of this opportunity to change hearts and minds and legislation and programming.
Thank you, Tracy, the rest of our panelists, and our audience for joining today. We are now going to get started with some of the questions that I prepared before moving into an audience Q&A. For those watching, please feel free to submit your questions throughout our discussion. So I'd like to begin with a question for you, Shannon. As mentioned before, individuals living with mental illness face a high risk for harm while interacting with law enforcement, as well as longer jail and prison sentences. This risk is even higher for Black and Latina folks. Could you comment on what interventions may be effective in reducing lethal altercations between individuals living with mental illness and authorities, as well as preventing their unnecessary incarceration?
Absolutely, Tanya. And before I really kind of dive in, I do want to just acknowledge to the audience that there is a lot to be desired in terms of reform in terms of policing in our communities. There's a lot of harms that policing cause in communities across this country, especially for communities of color. And so when I talk about some of these solutions specifically related to mental illness, I want to just acknowledge that this is not what is going to solve those issues, but this is a piece to that discussion. So I just want to acknowledge that for everyone. But, you know, we have long relied on law enforcement as a first responder to mental health crisis, and unnecessarily, simply because is there any other service in our country that is available 24/7, 365 days a year? You know, if you're looking, you know, mental health crises don't resolve themselves, happen and resolve themselves within kind of the 9 to 5 structure that we often see in mental health services. So a very long time, you know, NAMI has advocated for CIT programs, that's crisis intervention team programs, which has been, you know, a cornerstone of that has been law enforcement training. And for for a really long time, we have pushed for law enforcement training. But we're at a point in our country, and a really exciting point that frankly, I've heard a lot of people mention as a once in a generational opportunity, in which we have an opportunity to reform the way that every community in this country is responding to mental health crisis. At the end of 2020, Congress passed the 988 Designation Act, which designated 988 as the national 3-digit number for suicide and other mental health crises. In there, they created opportunities, and throughout 2021 and 2022, they have continued to create opportunities in which communities can fund and implement the 3 pillars that SAMHSA identified as a guidance that everyone should have who's experienced a mental health crisis. And those 3 things are someone to talk to, someone to respond, and somewhere to go. And so 988 fulfills that in having a telephone call, someone, a number to call and someone to talk to who might be experiencing a mental health crisis, an opportunity to not dial 911, who is automatically going to dispatch law enforcement and EMS, because that is what their responsibility is to do. We also see a lot of opportunities to create mobile crisis teams, which are staffed by mental health providers, which provide that alternative person to respond to mental health crisis. Someone that's not a law enforcement officer, someone who does not have the orientation of command and control, but has the orientation of, what is happening in someone's life when they experience a mental health crisis. And we're also seeing a lot of opportunities to fund crisis receiving centers. The number one complaint I hear from law enforcement officers is that when I interface with someone who's in a mental health crisis, I don't have anywhere to go. I get that I'm supposed to divert them. I get that that is the goal, but divert to what? And so what we see happening in a lot of communities is these crisis receiving centers sprouting up, which create an opportunity, a location for some place for someone to go who might be experiencing a crisis, a place for law enforcement, if they do come into contact with someone in a crisis, to take them to a receiving center where they can continue to receive mental health support and get connected to services back into the community. And so this is all happening right now. 988 goes live nationwide this July. We're seeing a lot of legislation happening in Congress. Representative Cardenas last week introduced the 988 Implementation Act. There's a lot of really exciting things. I know I'm trying to keep this short, so I encourage everyone to look at that piece of legislation, because I think that is what the mental health community has put out there as these are our asks currently in terms of finding alternatives to law enforcement being that first responder.
Thank you for your insightful response, Shannon. Training, diversion programs, and 988 are critical to supporting the needs of individuals living with mental illness. Absolutely. I'll now turn to Maggie, Karen, and Kate. We know that all individuals struggle while incarcerated. However, folks living with mental illness face heightened challenges. Could you each comment on what correctional mental health care should look like and what policy or social changes are necessary for these visions to be realized? And we can start with you, Maggie.
Okay. Yes, I want to touch on the social changes. And I just want to remind people that even if you did not have mental health problems before you went to prison, you are guaranteed to have them when you leave.
Yep.
I have several tics and PTSD moments that I did not have before. I have ways that I deal with things that normal people don't, and it seems normal to me because I lived in an institution for so long. And so these things I didn't deal with before, and I didn't even realize they were an issue until afterwards, trying to reintegrate into society that had already cast me out. And so I think that that's one of the major things that we have to understand. And then women as mothers, we have children, and it is very difficult to reintegrate and be a mother when this child is in school and knows that your mom's been in prison. And so then you have the child's mental health to worry about. And so I think that the major changes that need to be realized are humanity. We need to realize that everybody is human. When I went in for mental health care within the prison system, I was looked at as crazy. I was looked at as drug seeking. And not only was that a stigma from the doctor, but then you go back to your living area and you have to deal with that. People saying that, hey, what'd you get? What are you doing? So it is just such a terrible ecosystem trying to deal with mental health within the system. And then even when you get out. So I think humanity, kindness, and peer support, having peers within the system who can guide somebody, because I did not know that I was very stubborn about admitting to having a problem. And so I think guiding somebody through that and saying, yeah, I was there too. I didn't think I had a problem. This is not normal and it is okay to get help. So humanity and kindness and peer support.
Thank you, Maggie, again, for being so vulnerable and so open with your story. I really appreciate you shining light on your experience and experience with fellows like yourself. I'll now turn to Karen and then afterwards to Kate for your thoughts on this.
Thank you, Tania. I'm going to again go to Maggie's point. People do, if you come in healthy, you will leave with a minimum of PTSD. You will leave with post-incarceration syndrome, the constant state of your body's on high alert constantly. Even as an employee, my body changed immediately when I started working in a prison, and I got to leave every day. I was not stuck there. So I wanted to discuss 3 quick things that we need for change in order to begin the change process from the perspective of someone that worked in the prison. But again, to Maggie's point, what we're saying today is the most important issue that we face in the face of reform is the public's belief that once someone is justice involved, they don't deserve anything. They don't deserve rehabilitation. They don't deserve our help. They're no longer human. And until that changes, it's going to be a very long uphill battle for all of us. So I encourage people today, just keep that in mind. This was someone's baby once that was held in their arms and loved, and we just discard them because now they have a GDC number. And it was heartbreaking to see every day. It was really hard. The second thing I think that needs to happen as far as mental health incarcerated individuals goes is an accurate diagnosis, so we know who we are dealing with and what we are treating. The diagnostic centers and prison centers in Georgia they're laughable at best. When they get assessed, the people that are assessing them, they're not even considering the shock of being incarcerated or that they've just been bussed there like livestock to the diagnostic facility. And that does impact the interaction between the individual and the diagnostic team. You've been handcuffed for possibly hours, waiting in a bus that's not air conditioned. You've been bumped around all over the place, and now you're in a new prison, and they're going to tell you what's wrong with you, and you hope you get sent to a good facility. And that is going to create a very big disconnect between the individual and the assessment team. But without a proper diagnosis, a proper and thorough diagnosis, we can't change the mental health care that our loved ones receive. And then finally, the prisons need to have what's called an MFCO. It's a multifunctional correctional officer. And those individuals are supposed to be staffing the dorms with the mental health offenders. Without exception, only an MFCO should be able to work in those buildings because they are trained for de-escalation. They have some mental health background training, and they know what's going to be typical for that individual. And someone else working the building, if they see someone with schizophrenia that's standing in the middle of the room talking to themselves, they're going to assume they're on drugs. And sometimes that is the case, but more often than not, it's not. It's responding to internal stimuli. So a multifunctional correctional officer is the liaison between mental health, security, the warden, and the prison system in general. So once the MFCOs could be on board consistently and work with the mental health department, you can create a housing environment that provides therapeutic and recreational activities that foster safety, so you can then create personal growth and insight. As we all know, without safety, no one is going to come through the hard things that you're going to endure in prison, and everyone's mental health is going to be impacted.
Thank you, Karen, for sharing your perspective as a provider. I think it's really insightful what you've shared, and I'll now turn to Kate for her thoughts as well.
Thank you. And to both Karen and Maggie, I completely agree with everything they said. You know, we've built an organization, NIA, on the primary premise that the main reason for choosing to incarcerate an individual should be to repair that person, restore the circle of impact around his or her behavior or crime. So a little term we use, we say we want to fix the human robot. And we don't use that term robot out of insensitivity, but we fix our beloved electronics when they're broken. So we feel we should fix human beings as well. First, we really need to truthfully explore if, in fact, anything's actually broken, or is it just a prosecutorial win? Something can be broken irrespective of whether or not a jury got it right. And then second, we present to the sentencing judge a strategy of how to fix the human robot, and it's mapped out from the second they hit the prison system. It's a plan that's going to repair what was wrong, what's broken. And then thirdly, all the carceral facilities, all the facility resources and protocols, they're all fully channeled to apply to those strategies. You know, we've got to have testing and tracking, and we've got to have open public accountability. So central to this course of repair and restoration is full assessment of addiction and mental health, which is what Karen was talking about. So we have comprehensive healing, management, and self-sustainability. And I see some folks in the chat, you know, is there care afterwards? Is there, you know, everything is fragmented and disconnected. There are things out there. We just have to figure out how to connect them to initiatives. We already have a lot of the social innovation in place. We have all these resources for this level of reform. I think we're just caught up in the emotional theater of reacting rather than doing.
Thank you all for responding. I want to share that I echo all of yours hope for tomorrow in which compassionate and comprehensive mental health care is available for incarcerated individuals struggling with their mental health. And I'm really honored to be part of that fight with all of you. I'll now turn to Tracy. In our conversations, we have touched on how improving correctional mental health care is really an investment in community mental health care, since approximately 90% of incarcerated folks eventually return home. With that in mind, what sort of programs or services are crucial and effective in helping returning individuals experiencing mental illness start a new life? I think Tracy might be on mute.
There we go. Thank you, Tania. I wish I was on the part of the previous array of questions, because what it really emphasizes for me is, again, how deeply entrenched and how much we have absorbed, whether consciously or not, that we have abandoned health issues of the mind to carceral systems, to institutional systems. And a lot of that has to do with the history of, the history of the healthcare system not wanting to deal with people who have mental health and addiction issues. And there are various examples of that through the decades. And it almost spawns, as Maggie pointed out, due to our legacy of slavery and how we othered people. We have been othering people and their behaviors, and othering includes criminalizing. Stigma is merely a way to oppress people who are other. So acknowledging that we have, buried in statute and in programming this false split of dealing with the mind and the body is what has gotten us to where we are today. So when I talk about programs that work in the community, the fact that people, yes, they do return to the community post-incarceration, but they're also feeding the carceral systems. So the poor health care and the poor mental health services, or the lack of mental health services, creates a funnel and a constant cycle of engagement with a carceral system that is not really about rehabilitation or correction, but actually perpetuates harm. And then we have systems connected to the carceral system that also perpetuate the harm. I'm a person living in recovery. I have definitely depended on mental health services. I am aware of my privilege. I was not incarcerated, but in being involved in the child welfare system with my children and my family, it was very connected to carceral systems. Mm-hmm. So how does that heal? It didn't. It broke us. And being here today is by virtue of community supports and love of family and friends, but none of the systems that are supposed to help helped me be where I am today. Sorry about my voice. So I just want to talk about, again, understanding how we are where we are today and what we must unpack. It was important that Representative Tonko kind of helped to open this, because he has really stepped into the leadership role of talking about the failures of incarceration, of talking about harm reduction. And I'm a person in recovery who's also a harm reductionist, and there is no inconsistency in that. And the fact that we've created financial systems such that healthcare does not want to deal with people who they deem as part of the criminal legal system, right? So we have a Medicaid program that doesn't allow funding for people when they're incarcerated. And many states around this country either suspend or actually terminate Medicaid when people become involved in jail and prison. And if people are coming home again, what that means is that people do not have supports that they need and providers to provide that support, because they're seen as costly and that they won't get reimbursed. In New York, we're spending something like $300,000 a year on one individual in our jail system. And that's even more for a young person and even more for people with healthcare issues like addiction and mental health. We have invested in carceral systems and not in the kinds of systems that keep people out. And so carceral systems are now healthcare systems. I will end with saying our state correction system is the biggest purchaser of mental health drugs, bar none, including hospital systems. They are the primary purchasers because they are the primary place where people are getting their care for mental health systems. And until we see the immorality of that and the perversity of that, we are not going to change it. We are not going to change it. So I want to get off my soapbox and be able to engage with some of the questions that have come up, but understanding that we have a fundamental baked in disincentive to provide people with the kind of care that they need and deserve that keep them out of these damaging systems.
Thank you, Tracy. I think you really highlight and put into real emphasis the fact that the system is broken and we are not serving people and we are failing. And I think when we have this conversation, we have to think about the differential impact of who is being affected. So on that, I want to bring up the unjust overrepresentation of people of color, mainly Black and Latina individuals, in the prison and jail system. So how does the issue of correctional mental health care intersect with broader issues of racial inequality?
Well, right. I mean, and that's, the reckoning of whether you saw the movie 13 or you read Michelle Alexander's book, or you even saw how Black people have been treated by law enforcement and by carceral systems, there is no escaping the fact that there was a particular focus on criminalizing people, communities, and perceived behaviors, right? And that is, again, baked into these systems. So what we're impacting, what Kate's son experienced is legacy of the mandatory sentencing and the war on drugs and the mandatory minimums that were thought to be a way to address and other and stigmatize Black and brown people for political purposes, right? You just beware of a governor seeking to run for president. We have the mother of mandatory minimums, Rockefeller drug laws in New York, and we are still undoing it 50 years later. And those laws have shaped the landscape of health and health investment and mental health and addiction services since they were implemented. We still have a ways to go to not see people as at fault by virtue of health issues of their mind, right? And so the overdose epidemic is one example of where we are starting to recognize that our punitive approaches don't work. One of the things I wanted to bring up in terms of the services and how we have bifurcated through the kind of discrimination, What is the difference between discharge planning from a hospital and reentry planning for an individual coming home from inside? There should be none. There should be none. What Maggie talked about should not have happened. And the engagement of people who are inside with their families on the outside, when we put prisons and jails far away from the communities that they come from and can't allow for family bonding, that is an impact on mental health services, on mental health. And in addition to the trauma that people come into carceral systems with, we all are now understanding that the carceral systems perpetuate trauma. So where is the healing happening? Where's the rehabilitation? It's not happening in our modern construct of corrections. And we need to look at a different way that is about restorative justice, that is about reducing or eliminating harm, and that's about acknowledging how much of this country's history with racism and othering people and abuses in healthcare, which make people not trust the healthcare services that are available to them in the community. They avoid it, they decompensate, and they end up in our criminal justice system. We must fix it.
Thank you, Tracy. I couldn't agree more. And I appreciate your perspective because it is important to recognize how correctional mental health care is a racial equity issue. And if we don't treat it as such, we are going to continue to fail, and particularly fail people who are heightenedly vulnerable. I now want to turn and highlight the co-occurrence of mental illness and substance use, which is particularly prevalent among the incarcerated population. Starting with Maggie, then Kate, and then Karen, how should healthcare delivery across the lifespan of incarceration, so from arrest to post-release, be designed to support the needs of folks dually diagnosed? Take it away.
Okay, so this is substance use and mental illness are co-occurring in the free world, right? Before I ever went to prison, I was self-medicating because I did not understand mental illness. So there should be a continuum of care once you leave prison. I didn't know I was self-medicating before I went to prison. Then once I went in, I was scared to get help. And so, like I said earlier, there should be some kind of pathway to help somebody get into a safe space to where they feel like they can trust and take medicine or whatever. The therapy, trauma therapy helped me a lot. And once we get stable on these medications, we cannot be just thrown back into the streets. One of my biggest fears every single day is I've been stable for 5.5 years. What happens if I lose insurance? What happens if one day I cannot afford my medication? I suffered for 20 years. And so that is a major fear that I live with every single day. Can you imagine people coming out with no job, no house, no support? They've been stable while they've been incarcerated sometimes. And if they're thrown back out with nothing, how do we expect people to re-enter society and become working members? We can't. We cannot. And then we see all this homelessness and suffering. And it's painful for me to watch because I know it's not that person. They just weren't given nobody's going to be able to, you would not be able to make it if you get out. You have a felony, you have a mental illness, jobs don't want you, society doesn't want you, and then we're just casting these people away. So there has to be a continuum of care. We have to invest in human life, period. And so, there just has to be some, and I don't know how much to stress this, that if people get stable, for me, it was like a miracle. I spent 20 years in pain, suffering. And now it's like the greatest thing just to be able to function properly. And it hurts me to see that there are people that don't have that care and they don't have access to that.
Absolutely, Maggie. I share the disappointment in the system that continues to fail people and continues to not recognize their humanity. I'm now going to turn to Kate to add more of her thoughts.
Thank you, Maggie, for sharing. She's 100% right. Let's use my son as an example. He went in as a full-blown heroin addict and also had underlying mental health disorders that were not diagnosed, as Dr. Eichenberg mentioned in the diagnostics when he went to prison. He spent 6 years in state prison, never learned any kind of skills, never had any treatment whatsoever for either his substance use disorder or his mental illness. He was released October 2018, and Daniel passed away this past August 2021 of a fentanyl overdose. The continuum of care that Maggie mentioned is the critical and the largest gap that we have. There is no continuum of care. Like she stressed that while you're incarcerated, now my son was stable in prison because he was relatively sober there, although drugs, as Karen will tell you, are rampant in the prisons. It's easier to get drugs in the prisons than it is in the streets. You're not going to get arrested for drugs in the prison. I'm sorry, you're just not. So he was relatively sober for the 6 years he was there, but he never treated his underlying disorders that caused him to self-medicate. So coming home, those post-incarceration syndrome and PTSD type things are real. The triggers started hitting him fairly quickly. The early triggers are just going to the grocery store and the overwhelming amounts of choices in there that he couldn't even figure out like how to do this. Or the loud banging of a clanging door would make him jump. Not thinking to turn lights on or off or shut doors. He had no ability to kind of really like do what we just take for granted every day when you're not institutionalized. His major triggers occurred when he was in the hospital while his fiancée was having their child, and he was wheeling a plastic cart down the hallway, and he had a major anxiety attack. And he said, "Mom, I feel like I'm back in prison," because a hospital is very much like it's an institution. It's very familiar to him. So that was one of his first setbacks. He picked up a pack of cigarettes that day. He hadn't smoked in years. We did not know what was going on in his head because as a man, and probably Maggie could relate, you got to protect that space. He doesn't understand what the trauma is. He's got it all packed up in this little package. So he looks really good. He's behaving well, but inside he's got a lot of trauma that's not unpacked. Once those triggers hit, the only thing his brain knew to tell him to do was self-medicate. So he started back on the pills, and then next thing you know, back to heroin, and finally the fentanyl overdose. So when we're thinking about how do we fix people, what do we do? Assessments at sentencing. What was wrong with Daniel Basha when he went to prison? Why did he commit this crime? What was the underlying things? And he's got substance use disorder, but he's also really gifted and he wants to be an architect. So we should probably not only treat what's wrong with him, but also lift what's right with him while this entire 6-year journey. So my son could have come home 6 years in sobriety in full, long-term recovery and with a master's degree. Instead, he's dead. So, people might say, Kane, why do you continue on? Because all of you listening today, you don't understand the critical importance of you to push your lawmakers, everybody. And I'm not saying from the president down, I'm saying from the dog catcher up. It's time for us to stop this nonsense. Maggie's alive by the grace of God because nobody's out there helping her. I know. We're trying, but the fragmented society that we have allowed to happen, allow people to fall through the cracks it's not acceptable anymore. And I think this kind of conversation is critical, and I know that we need to continue.
Thank you, Kate, for sharing, and my deepest condolences for your loss. I want to say I really appreciate and hope that you feel like this work is honoring the legacy of your son. I will now turn to Karen to also add her thoughts.
Thank you, Tanya. It's hard to imagine the amount of drugs that are in prison, and it's also hard to imagine the amount of boredom. I describe prison as deprivation. It's the lack of peace, the lack of quiet, the lack of sleep, the lack of food, the lack of clothes, the lack of heat in the winter and cool air in the summer. That is what prison is. It's the lack of everything. And then, of course, the lack of your family members. You're not hugging your children. You're not hugging your wife or your mother. Your family members are dying, and you can't see them or communicate with them. So that is the prison experience. It's complete deprivation. Drugs are a way to kill time. You're bored to death. You have nothing to do. And so you get high, and then you get very high. And when you have a mental illness, not meant to interact together, but it is so readily available. Bricks and bricks of meth and weed and all kind of stuff, and fentanyl, it's everywhere. So it's not difficult to get. That's not an exaggeration for people in the free world. It's there. And we played, and the mental health department was like, is it schizophrenia or is it meth? Like, it took you a while to figure out, because they look similar, like 40%, and they go like this, but they're very similar. So there's a big learning curve when you're working with this population. But kind of from me, again, from the perspective of someone that's worked inside of a prison, my answer to this question is it's really hard, because like in a jail setting, you cannot force medicate anybody. So you have somebody that's come into the system for whatever the charge is, and they're in true psychosis and they're harming themselves, and you cannot medicate them. Well, once you're in prison, now we can force medicate you. Now we have involuntary medication. So if we think you're not behaving appropriately, if we think you're too active, or if we think you may be dangerous, you will now be on involuntary medication. And what that is things like Haldol and Cogentin. That is meant to slow folks down. However, it also causes people not to be able to move. They can't physically get out of bed. So what individuals have discovered is if you microdose meth, it's like having Adderall. So now you're able to leave your bedroom. Now you're a little safer, because you can defend yourself if someone comes into your room to try to steal from you or try to kill you. So microdosing meth is the incarcerated individual's response to over-medication, because in prison, you now have no more autonomy as far as what you do or don't take if we think you deserve, if the powers that be think you deserve that. But I feel like in order to treat duly diagnosed individuals, several things must change. The number one thing is you have to provide meaning for justice-involved individuals. There's nothing for them to connect to. Countless studies connect the lack of meaning and past trauma to drug use. And this is especially true of those in our mental health population. Their environment is devoid of meaning. And once they've been incarcerated for a while, especially with mental health issues, their families abandon them. They're lucky to have anyone that they still talk to. So they turn to drugs to feel something, whether it's peace or quiet or energy. They're looking for that, to get that from a drug. If you give people with meaning and properly diagnose and medicate them, they will not turn to drugs. There's a wonderful book by Johann Hari called Chasing the Scream. And it's about curing drug addiction. And the number one thing that they found with all of these trials is when someone has meaning, they will stop using drugs naturally. So that's easy to create in a prison environment. And the second thing I will bring up today is if you provide a safe environment, so others who are not on the mental health caseload, they won't end up turning to drugs to deal with the PTSD that the prison creates, and even the most stable of individuals. There's no one who lives or works in a prison that is not on high alert 24/7. So if we just simply create a safe space for them and give them meaning, you will literally see the majority of the drug use disappear, and it's not cost anyone a penny.
Thank you, Karen. As always, I really appreciate your perspective from being a provider. All that you've shared is really insightful and helpful. I'll now turn to my final question from my moderated section, and this one goes to Shannon, and it's about the impact of the pandemic. So over the last 2 years, COVID-19 surged across prisons and jails. How did the pandemic impact the delivery of correctional mental health care and the day-to-day lives of individuals with mental illness?
Yeah, so I'm going to address this a little bit from the community perspective, as I kind of mentioned that the limitations to the mental health system overflow into the prison system because our communities have limited resources. And then I'm going to let Dr. Karen talk about some of the kind of barriers they faced inside. But the COVID-19 pandemic had a significant impact on America's mental health, period. Prior to the pandemic, around 1 in 10 Americans reported symptoms of anxiety and depressive disorder, and 47 million Americans reported having any kind of mental health condition. And as a result of the pandemic, we saw an increase of 4 in 10 adults reporting symptoms of anxiety and depression, with over 56% of young adults between 18 and 24 reporting any kind of mental health symptoms. And so when you have this increase in people experiencing mental health conditions, in people being triggered by what is going on in their environment, there's an increased demand on the mental health system. There's an increased need for care. And prior to the pandemic, we were already seeing a significant shortage in providers, in just sheer access to mental health care in the community, meaning people who are struggling, who haven't even come into contact with the criminal justice system yet, can't get the care that they need, can't access the providers they need in order to kind of get that care that can stabilize them in a community, that can prevent some of those interactions with law enforcement and that lead into continued involvement in the criminal justice system. Right now, we're estimating that we need 6,600 providers, 6,600 practitioners in order to meet the needs of people in America, people in this country, in the community. That impacts almost 132 million people across this country, because we can't possibly bring enough practitioners into the field that truly want to meet the needs of people. I will also just say, even if we do bring in 6,600 practitioners, the people who are willing to take on people who have co-occurring disorders, who have serious mental illness like schizophrenia and bipolar, people like Karen, who are willing to serve inside prison systems and work with people who have re-entered our community, those types of practitioners are so few and far between. This is tough work for practitioners. Working in that carceral setting is not easy. And so, we don't pay them well enough. We can train all the providers we want, but until we are willing to pay them and provide them with the support and resources that they need to serve our communities, these problems that have been brought to light by the COVID-19 pandemic are only going to be perpetuated. We are only going to, again, continue to rely on the justice system because, we've talked about this continuity of care and this system of care. The only place in the United States that you are entitled to health care and health treatment is inside a jail or prison. That is the 8th Amendment entitles you to get treatment once you are inside a jail and prison. You are not entitled to that outside in the community. You're kind of on your own. And so, for people, like Maggie and like Kate, Kate's son, who have, really need to stay connected to care, we've created 2 parallel systems. And I realize I'm getting away a little bit from the COVID, but this all kind of relates. We've created 2 parallel healthcare systems. When you are in the criminal justice system, you are getting one set of care. The second you are out, you are transitioning to a different coverage of your healthcare, different providers, different types of treatment you might have access to. It's just not the same. And that is hugely disruptive to people. So I wanted to kind of make that point as we're talking about kind of mental health care and just access in general, because I think that has contributed, to some of the barriers that we face to keeping people outside of the system and even providing care for people inside the system. Because if our providers don't want to continue to provide that care, we face some challenges there. But I do want to make sure that we focus on the COVID. I diverted the conversation a little bit, but I'm going to turn it over to Karen because I think she can provide some really great perspective on just the barriers providers faced inside the system as a result of the pandemic.
Thank you, Shannon. We can all do TED Talks on every topic all day long, every audience. Thank you for bearing with us. I'm a walking TED Talk about prison reform, so thank you so much. As far as the actual happenings inside of the facilities during the pandemic, the general population, if someone got COVID, you were thrown into the hole, you were locked away, or the entire dorm was locked up. But focusing on mental health specifically, what happened to those individuals is, again, the deprivation. They didn't even get to leave their building for chow. Chow was run to them, which meant they got less food. They had to eat all their meals earlier. So someone on medication that's starving all the time, just from virtue of medication, they're having breakfast at 5:30, which they're not awake for. Lunch is at 10:30 and dinner's at 1:30 or 2. And if you are medication, the medicine, you're starving. Your body is telling you you're hungry and you need to eat. And it wasn't happening. They were never allowed to intermix with other members of the dorms. And then, of course, staff was cut by about half. So you don't have the typical activities that you have, which are pathetic as it is, but now you have even less of that. So now we're giving people coloring books on their own, no activity therapy. Therapists are spread thin. And so it was hard to use. You can't see some of your people because they're also on lockdown. So there was just really a massive amount of neglect and then a massive amount of really of just solitary because they weren't allowed to interact with people in the camp, especially the mental health individuals. I'll cut it off there.
Thank you both for responding and giving such depth answers to what was happening during the pandemic and what is still ongoing, because of course the pandemic is still here. We are still dealing with it. I'll now turn to the audience Q&A. We may only have time for 1 or 2 questions, but I was interested in really getting to, I would say, Fatima's questions when she asked, what can communities and local agencies do to ensure a safe transition for those who were formerly incarcerated?
So I see also that we want to flag, and apologies for getting kicked off by my internet, some of the policy issues that people should be aware of that are happening. And I would highlight legislation that Congressman Tonko talked about, the Medicaid Re-Entry Act, that would provide funding for people prior to release. That is something that is very popular, has bipartisan support, and we hope will get passed. We tried to do it in New York through our Medicaid waiver, and the recognition in particular of that vulnerability to overdose for people coming out, and that who, medication, agonist medication in their bodies protects them from the overdose, from a lethal overdose. So we are now trying to have correctional environments be able to supply that medication, but let's never forget that corrections' primary goal is containment and control, and that does not align well with improving health outcomes or dealing with people with acute illnesses, or even addressing illnesses in a way that people generally wait as long as possible before they access care. Another element people should be aware of is the opioid settlement funds that have been, that are going to many states that also happen to have high rates of incarceration among people with serious mental illness and addiction. Those dollars should and can be used to expand our resources in the community to improve services. And I say this because I lived through how we were able to use HIV funding to build health infrastructure, both inside and outside. And in New York, we've been able to see some very wonderful outcomes for people with HIV who are incarcerated and people with hepatitis, because we created a mandate of collaboration between health and corrections that doesn't exist anywhere else in the country. So just some things to stay aware of. Again, we'll all have to work together to make it happen, but there is some responses and solutions on the horizon.
I am realizing now that despite having a wonderful conversation and really bringing incredible insight across all our panel, we are running out of time, and I really appreciate the audience for sending in questions. And of course, we'll have all the folks here on our panel be able to respond to questions because their contact information will be there. But I now just want to turn back to all our panelists to give us each a moment to just really give insight on this one final question. It's, if you have our audience take away one thing from today's panel, what would that be? And we'll start with Dr. Karen Eichenberg.
Thank you, Tanya. I think the biggest takeaway, what I've seen just from being involved in different organizations and being inside of a prison, no one is winning in this system that we have up. Where the victim, there's not really getting justice. You're creating multiple victims by one sentencing act. Family members, providers are taken away, children, spouses, whatnot. So no one is winning in this system that we have right now. What really is needed is a complete system overhaul, because what we have is individuals and their families that are suffering mentally, emotionally, and financially. What you say inside is that your family and community is riding with you. So it's not just the individual that we've separated from society. It's everyone in their system is suffering. And so I really just encourage everyone, do what you can to get involved in this fight, support prison reform, correction reform. It's an exciting fight. I love it. I'm very excited to be here. And thanks again for everyone's time today.
And now we'll turn to Shannon.
Yeah, I'm going to keep this really short so I don't get back up on my soapbox. I'd say connect with every organization that's on this panel today. You can go to nami.org/advocate for change to join our advocacy email list. We're gonna, we constantly send out updates and information, both about federal and state policy, both on, efforts to reform the criminal justice system as well as the mental health system. I will also give a pitch. I follow Legal Action Center. They send out lovely information all of the time. And then, again, all of our Twitter handles, the NAMI Advocacy Twitter handle, definitely, again, is another way to easily stay in contact with what we're doing, and just continue to engage with all of our work and figure out other ways to get involved in your community. So again, thanks, Tracy.
And now turning to Maggie.
Yes, one thing that I want to always remind people is that we come home. We don't all get life sentences on the inside. And how we're treated in there affects how we return. And so we end up trying to work in a society that damaged us and will not accept us. And it's very difficult to try to just fix that in your own head and then to be looked at in a very condescending way. It's not good for society as a whole, and we don't get life sentences on the inside, but this is something that all of us will have to contend with for the rest of our lives, no matter what the charge was. And so I just don't think that this incarceration system is doing the community any favors at all.
Thank you, Maggie, for really highlighting the need for change. And now turning to Kate.
For me personally, this is a movement. This is a movement that the families of the impacted can make some serious change because you have one tool. It's your power of your vote. And for my takeaway to ask for you out there, the audience, to learn more about this conversation, really study it. You have some good questions here. There's a lot of information out there. The NIA has a lot of answers for you, as do the other organizations. But the power of your vote is your most powerful tool. So understand what the issues are that impact you and your household and your community, and push your lawmakers to stand up and do the right thing. So that's our saying: stand up, show up, and speak up.
Thank you, Kate. And finally, Tracy.
I think the last thing I would want to impress upon people is that change sometimes happens quickly and sometimes slowly. Some folks will recognize that term, but the advocacy work is essential even if you're not around to see the results. You are standing on the shoulders of people who have allowed us to get to where we are, and you need to be the shoulders that people stand on to continue this work.
For sharing with us today, and being so generous with your time and expertise and experiences. I have learned so much from our discussion and have no doubt that our audience has too. Thank you to everyone who tuned in for your interest in addressing the mental health needs of incarcerated individuals. And thank you to all the folks at CHCI. I speak confidently on behalf of all the fellows when I say that we are so grateful for all of your support and belief in us. And thank you to all of my cohort mates. It has been an incredible honor to build community with all of you. As we close out this year's Capitol Hill Briefing Series, I urge us to consider the great possibility of this moment. Over the last few years, the U.S. has begun to rightfully reckon with the fraught role of the criminal justice system in our society. And among its various ills, the harm that the criminal justice system poses to individuals living with mental illness is clear and utmost concern. We should not and cannot stand idly by as correctional systems become poor substitutes for true mental health care. It is a matter of racial health and criminal justice. So I ask that we all share and build on the learning we have done today. I ask that we honor the lives and promise of our community members behind bars. And I ask that we commit to creating and defending opportunities for community healing for all. Thank you.